If you're building your ABA company and you're tired of guessing, this is for you. We built the EBCBA blueprint to give you real structure, systems, and support without the fluff. Details are in the description.
All right, welcome everybody. As you guys know, our group here, our ABA Business Challenges group, is run by our ABA Impact team. Our goal is to get you guys as much help as we can get you for free while you're getting your businesses started up or getting your businesses back on track after you've been running for a while. Whatever it takes for us to help you make a positive impact through your ABA therapy business on your community, our society as a whole, and to help the kids that need the ABA therapy. The early intervention is our focus always, because that's what I've seen. That's what I have a personal connection to, and that's our focus. But anybody who is on this group who needs help with anything on the business side, we always talk about how the caretaker mindset is often met with a lot of unique struggles trying to run a business, because it's two different mindsets you have to be. You have to switch back and forth between clinical and the caretaker perspective and the business and the administrative perspective. So today's talk with Jerome is a major administrative issue, and making sure that you have your T's crossed and your I's dotted when it comes to your clinical documentation and your compliance on this side. And Jerome and our team have, of course, hit it off. We have a lot of common struggles on both sides as we're doing the technical compliance more on the business side, the business processes, and Jerome's focusing on the clinical compliance. There's the same struggle there where a lot of people we talk to really don't have a focus on what they should be focusing on when it comes to the compliance stuff. Because you think, I've been running my business since 2009. I've never been audited for taxes, sales tax, employment, any of that stuff. But we've always run our business in an audit ready stance. So I've always said we got to be ready for an audit. So we pretend that we're about to be audited all the time. So if you just put yourself in that mindset and just stay there all the time, where you're always ready to be audited, you're always ready to deal with a data breach, you're always ready to deal with the power going out in your building, always having a plan, always thinking about these things ahead of time, it's much easier to deal with. And you also invest dimes instead of dollars. If you do it ahead of time, it's much easier. So for the last 15 years, I've been running my business in an audit ready stance. And we finally just got audited this year. And I was almost excited. It was like, okay, we're getting audited, but hey, this will be cool. We'll finally get a chance to prove that our stance is correct, that we're doing all this for something, right? It was for the Florida unemployment tax. But within a couple of hours, we had all the documentation done and sent in, because we're in that audit ready stance. And I think that really needs to be our focus. Where does Jerome and RadBx come into all this? Jerome is the owner and lead consultant of RadBx. And he's also an associate of the Autism Insurance Resource Center, where he works on your ABA business is to resolve issues with insurance coverage, support families as they're trying to get through navigating this insurance landscape. And Jerome's been working over his last several years in business to establish Medicare coverage of ABA services in Massachusetts, right? So he's been working on that, made a lot of progress. He started doing that in about 2015. He's dedicated his professional career to ensuring access to quality ABA services. And his current focus is on enhancing the quality of treatment and improving access to care. Jerome is a BCBA and an LBA in Massachusetts. He holds a master's in childhood and early childhood special education from NYU Steinhardt, and a master's in public administration from Suffolk University. He also graduated from the Leadership in Education and Neurodevelopmental Disabilities fellowship program through the Shriver Center at UMass Memorial Hospital in Worcester, Massachusetts. Okay, that's a huge bio. We have a lot of credentials that just reading through the degrees and the experience and the initiatives and all the things that you're doing there. Did I mess any of that up? Jerome?
Worcester.
Yeah, it's pronounced Worcester.
Okay.
I had to learn
all
that
right.
too. I'm a transplant from New York, so I
I'm
had to learn
from Florida, so forgive me. You New Englanders do things a little bit differently up there. So yeah,
absolutely.
And
my sister lives there, so that's why I knew you butchered it.
And my roots are in West Tennessee, and a lot of my family lives in a town that is spelled Bogota, which in Colombia is pronounced Bogota. In West Tennessee, it's Bogota. So we don't do things the way that we're supposed to in the South, and I understand that. So
amazing.
So Jerome, take it away. I can't wait to see your presentation.
Derek, thank you so much. I'm appreciative of this opportunity to speak with you and your group. When we first spoke, I knew right off the bat that we had so many similarities in our approach and in our missions that when the opportunity to speak came up, I'm very happy that we were able to line this up and get this going. Like you, Derek, and your team, my goal is to get people to understand the challenges of the world around them, to understand what compliance actually means in the healthcare market. The reality is ABA is a relatively new service in the health insurance landscape. And as such, there's a lot of growth that needs to happen. And from my perspective, having been a clinician who's worked in the field and also worked on the health insurance side, I feel like the reason why I stopped working on the health insurance side and started consulting, which is really the core of why I'm here today, is because once I learned what the actual standards were and how businesses were supposed to be ran, and I saw all these mistakes happening out in the field, I got very concerned with providers not doing things properly because I understood the implications of not being in compliance, of if a provider's not doing things at the industry standard. I met plenty of providers who didn't even know what the industry standards were, and I still do every day. So really what I'm trying to accomplish today is to make sure that everyone leaves this meeting with the core information necessary to start ensuring that they're in compliance for their businesses. And I look forward to going through this materials with you. And again, thank you for the opportunity. I'm looking forward to this.
Awesome. We're glad to have you, Jerome. Thank you for taking the time to put this together.
Of course. Okay, so let's move on to the presentation. Just as a standard disclosure, this presentation is not legal advice, and nothing that I say today should be taken as legal advice or even specific advice to you or your group and your practice. We always encourage providers to consult with their attorney and legal counsel if they need any advice before they take any actions. Additionally, I am not your consultant. I'm not telling you what to do. None of this should be considered actual advice for your practices. If you'd like to have a formal arrangement like that, we would need a contract, which I'd be happy to talk about in the future. But this is just general information that I hope you all find helpful as we discuss compliance and health insurance. Before we get going on all the topic, I just wanted to share a story. Because I had the opportunity to work as a clinician and work on the health insurance side, as Derek mentioned, I helped set up the Medicaid program for ABA in Massachusetts when I was the clinical manager at Beacon Health Options, and we implemented the ABA benefit really over many states east of Texas. We managed Texas, we managed Florida, we managed North Carolina, New York, Massachusetts, New Hampshire. I'm leaving out a few, but I think you get the point. We covered ABA authorizations and services over much of the eastern part of the country. And with that information, I learned what the standards for health insurance were, what the standards for behavioral health were, what the standards for prior authorization are. And because of that, I now have the knowledge and ability to act as a source of information, an expert in the field, in this space. And as such, I often am asked by both providers and health insurance companies to act as an expert witness for cases between providers and health plans. So when a case is brought by a provider, it's because they think that a health plan is doing something inappropriately. If a case is brought by a health plan, it's typically because the health plan thinks the provider is committing fraud. So I work on both sides. I'm not just pro health plan. I'm not just pro provider. I try to stay right in the middle and offer my guidance that will hopefully lead things to an outcome that, again, pushes the field forward and establishes standards of care that are improving and pointing in the up direction. But I want to talk about my most recent case because I think it's quite illustrative of what happens out in the field. In my most recent case, it was a center-based provider. The case was brought by the health plan, and I was hired by the law firm representing the health plan to act as an expert witness and explain what standards of care are and what standards of documentation are. But this was a provider that was center-based, and their motto was that they only offer 40-hour comprehensive programs, and they only work with patients that are high functioning. This is what they focused on as a service model. Their documentation was weak. Actually, their documentation was almost non-existent. They did have notes, but they often didn't talk about ABA services. The notes that were submitted to audit in many instances clearly could be seen as being falsified. There were lots of copy and pastes. There was lots of duplicate times. There were appointments that were supposed to be on the same day delivered by different people at overlapping times. A lot of it didn't make sense from the documentation perspective. They also had copies of internal audit materials that had also clearly been falsified. So they created documents that were supposed to act as time checks, and all of those were falsified as well, we could tell with analysis. So they were making up documentation, they were creating false documentation, and even the documentation that was there was very weak across the board. In addition to that, we had staff attestations that they were called in for a meeting and all given stacks of sheets of paper that they were supposed to sit there and sign that had been filled out by the owner. And the staff sat there and signed all these timesheets and notes that were all falsified. And they were supposed to say that they were the original documents because they were trying to cover the fact that they were committing fraud. We even had family attestations that stated that services did not occur over specific periods of time, like holiday weeks. A family would say, we didn't receive any services between Christmas and New Year's because we were visiting our family in Montana. But then when you look at the claims, the provider had stated that they delivered over 40 hours of services that week. So there was clear concerns regarding documentation, claims, and everything that was happening there. They also had to create a term called impossible days, which are days in which they had a single BCBA billing for over 24 hours of services in a single day, which is not possible. So they had to create a new term to cover this case. And initially, and I can't get into too much detail because this case was sealed, but I can assure you that the recoupment that was originally asked for was over $10 million. Now, what happened in this case got to court. It took almost 2 years to get there, ended up going to court, and ultimately at the excuse that was given time and time again was that the provider didn't know what they were supposed to do. They didn't know that they were supposed to keep detailed session notes. They didn't know what details were supposed to be in the session notes. They thought everything they were doing was above board, and they kept saying, I didn't know that. How was I supposed to know that? I didn't know that. How was I supposed to know? And the reality is when you sign a contract with any health insurance plan, if you're in network with them, you are responsible for every point in that contract. You're responsible for upholding every standard in that provider manual. And you need to go through the diligence of identifying what standards you're held to before you even sign. And that's the most important thing. You should never sign a contract until you understand what you're committing to. So their excuse of I didn't know, it's not valid. It is the reality. As we said, the provider basically just said that they didn't know that there was a problem. And the reality is it's saying I don't know it will not hold up in court. The resolution of that case that I was just describing, it was actually a very interesting situation. In healthcare as a standard, 80% of the fraud and recoupment cases don't go to court. 80% get settled before you go to court. In this one case that I was describing, it actually did go to court. And it's really interesting. I'm actually not able to call myself an actual expert witness yet because I've never been sworn in. I was actually scheduled to testify in that case on day 4. On day 3, there were a bunch of details that came out of the case. And then the other side, actually, they settled that evening because they realized that they were going to lose the case. So the health plan won that case. I don't know for what. It was sealed. I don't know what the settlement was for. I'm going to assume it was for more than $10 million because the health plan was very happy with the results of this. But can you imagine having a situation where you're being asked to pay back more than $10 million to a health plan, that will end most groups. That would bankrupt most groups. And I just don't want to see that happening to any providers. I don't want to see any, I've seen enough of the situations where providers are getting in trouble for things they didn't know were responsible for. I have made it my mission is to educate providers and make sure that they know what the standards are so that they can do their best to uphold compliance and make sure that they're doing things properly. So again, the I didn't know is not going to hold up in court, I can assure you. So it's our responsibility to know. And for that fact, I congratulate all of you for attending because you're going to learn something today. And hopefully that helps you get your practices into a more compliant situation. So just I've used the word compliance a lot. I just feel like it's important to start at make sure everyone's on the same page here. Compliance is the action or fact of complying with a wish or command. In health insurance language, it's the act or fact of complying with the contractual obligations of being an in-network provider. That's really how I interpret it. And I can't tell you the number of providers I've met that didn't read the contract, who didn't pull out the things that they were responsible for, and did not read the provider manual to understand what they were supposed to be doing. They just signed a contract and they started delivering services, and I understand it. It's exciting when you start delivering care, but you really need to read line by line your contracts and the provider manuals. You can skip certain sections. Like you don't have to read the provider manual regarding hospital stays or outpatient clinic or partial care facilities or rehab facilities, but you do have to read in its entirety the sections regarding outpatient services and behavioral health. And you have to read in its entirety the pre-auth services, because those have things that are you're responsible for as an ABA provider, being an outpatient pre-auth service. And in addition to the ABA section, because there's usually one specific for ABA as well. But don't just read the ABA section, because there's going to be parts of pre-auth that you need to know as well. So just, again, read everything and make sure you're folding all of that into your practice before you start delivering care. Okay, so I'm not going to have enough time today to go through all of these, but I just wanted to go step by step what my process is to ensuring compliance. Step one is identifying what your standards, policies, and procedures will be. You start this by reading all your contracts and the provider manuals and making sure you're in line with the contracts to which you need to uphold. You then establish a compliance program in your company. You establish a process of monitoring, of upholding these policies, of implementing these policies. You are constantly screening and evaluating your team to make sure that they are engaging in behavior that aligns with the compliance program. You need to continuously communicate, educate, train on issues ongoing to make sure that your team is staying up to date on their responsibilities and how to navigate the compliance space for your organization. Again, constant monitoring, internal auditing, and reviews of your systems. Again, we need to be disciplining anyone who does not engage in a compliant behavior. And that can be anything from additional training to additional feedback and supervision, all the way to termination if they're doing something egregious. And again, we need to investigate and remediate all issues that come to light. This isn't even a comprehensive list. This is the core of what we need to do when we think about compliance in ABA. Now, most organizations have the policies and procedures down, right? They have an employee manual. They work that all out. They probably had legal support to get to that point. But after that is where I find many ABA provider groups are struggling. It's the actual implementation of the compliance program. It's the ongoing training, because there's a lot of complexity in training staff when you're an ABA provider and you have therapists, BCBAs, and admins all over a state. It's difficult to pull everyone together for training. And it's also difficult to have an ongoing monitoring system. Compliance is a constant challenge, is the reality, but you need to fold pieces of your compliance system and program into your daily practice. And that's the best way to do it, is if every day you're taking a bite out of the compliance cake and you're doing your best to work away at it, it will put you in a place where you will be much more compliant than if you just try and do this once a year or twice a year. It has to be an ongoing process, and engaging in each of these activities or assigning responsibilities to your team of people who can keep track and monitor these things. Okay, so why is compliance important for health insurance? First of all, it protects patients. It ensures that there are appropriate practices occurring, that doctors are engaging in best practices, that they have the supplies they need to engage in high quality treatment. So, number one, it's to make sure there's quality care for the patients. Two is it avoids legal risks, which can be financial fines or criminal prosecution if it reaches a certain level. We don't want to see any clinicians going to jail. I want to see clinicians practicing and supporting individuals with autism who need it. Okay, so compliance also promotes ethical conduct. It helps identify problems early before they explode. It can improve overall operations of your company, making them more efficient. Again, this is very important for ABA providers. I find that many of the processes that ABA providers have are inefficient. And what does that mean? That means that you have to dedicate more resources to doing something or keeping track and monitoring things than most other industries need to. And that has financial implications. It makes the cost of running your business higher. It means you have to hire more people to do a simple task. And a big part of my work is ensuring the efficiency of the system in ABA organizations to make sure that they are making a profit and that they can manage things more effectively. And then finally, along with improving operations and efficiency, it's ensuring financial health. In the most real way, it's avoiding that over $10 million fine. In the day-to-day way, it's making things more efficient for your company and ensuring that everyone knows how to do their jobs and that they have the supports they need to do their jobs well so that they can bill health insurance companies and you can make money. This is all interrelated as we think about compliance. Okay, so the reality is if you have a culture of compliance, it will give you peace of mind. Like Derek was saying earlier, if you have compliance built into your company, you're looking forward to the next audit in a weird way, right? In a weird way, you're thinking like, I want to test the system I've created to make sure that I have everything all lined up and everything is going well. So we're doing this to ensure that we have some sense of assurance that we're doing things properly. Right here, I have a little shout out to the Insurance Guru, which is a character that was created by the Insurance Resource Center, which provides information on health insurance and answers people's questions. It's a Facebook group. It's a little plug. If you're interested in learning more about health insurance and coverage, the Insurance Guru on Facebook is a great resource because it puts out weekly posts. A little plug there. Now, the other thing is that the reality is that having a culture of compliance gets you peace of mind. But there's another way to get peace of mind, and that's through ignorance and just ignoring the fact that you're responsible for these things. I have found that there are a number of providers out there who don't know what they're responsible for, and therefore they think everything's fine. And those are the groups that concern me the most because they talk about having excellent compliance programs. They talk about having all these systems in place. But when you actually look at the system, you find out there are major gaps and holes, or they have completely misunderstood their responsibilities completely, in totality. And as such, they're really out of compliance, even though they think they're doing it properly. There are two ends of the spectrum. Both of them lead to peace of mind. But ideally, I want you to be informed and have a quality program and system, and have a culture of compliance so that you can rest assured that your business is operating properly. So where do most providers go wrong? These are just some common issues I see. Many providers think that the session note templates provided by electronic medical record systems like Central Reach, Rethink, Raven, Hirasmus, any one of those systems, they give you these templates and they say, use this to document your session notes, or here's the SOAP note template. The reality is those templates very rarely actually meet medical necessity. They very rarely meet industry standards for documentation. They most often have gaps in information, but providers think they're covered because they're using the template from their system, whichever it is. I've actually yet to see one system that gives you a absolutely comprehensive session note right off the bat. I've had to modify every single one of my clients' session notes that I've worked with because it's missing critical information. But in the sense of ignorance, many providers think, oh, I got a template. It's good. Like templates aren't good enough. A good template only gets you a third of the way there. Don't think you're covered just because you have a template. The other part of this is providers do not set up adequate compliance policies, procedures, and protocols. They have compliance procedures. They might have identified a compliance officer for their company, but they've rarely tested out their system to see if it works. And a big part of ensuring compliance is actually testing out the system, making something go wrong and seeing if it gets caught, seeing if your system is operating the way you intend it to. It's not good enough just to build the bridge. You got to walk over it and see if it holds you up. And this is the part I often run with my clients is testing their compliance to make sure that it works properly and getting it to a place where it does. Now, again, the most salient point here is the fact that if you aren't in compliance with your health insurance contracts, they can recoup the money. They can take it back. They can issue financial penalties, and or you can end up in court and there can be criminal findings. Now, this is where I have been living for the past few years more than I want to be. I don't want to be an expert witness. I do it. It's interesting work, but every time it happens, it's very frustrating to me, just on a personal level, to see an ABA provider who really meant to do good, who really went out there to do good work, and they're being brought to court and spending hundreds and hundreds of thousands of dollars defending themselves against a health plan. I don't want to see this anymore. So I'm making an active pivot in my own career and my own trajectory to educate providers more so they're aware of what they need to do. And I hope that this meeting today and all the work that we can maybe do in the future can help shed a light on that. Now, most people think people committing fraud or doing things inappropriate are scary looking people who are dark people on the web. This is not really true. The reality is the people who end up on that bench and are defending themselves about health plans, they look like everyone else. They look perfectly normal. They're very nice people. Most of the people who work in ABA are very nice, kind people. And that's the scary part to me. When I see these people on the stand, I'm thinking, wow, that looks like my first supervisor, or that's something I might have done in a previous life. And it's just scary to me how often we run into situations where providers are not aware of the things that they violated, leading to major financial penalties in the cases that I've seen. So what do we do to avoid this? First of all, we need to read our contracts and the provider manuals and make sure that we can account for and have those requirements built into our processes every day. We need to identify the compliance criteria, which means that we understand the contractual obligations along with industry standards. And I'm so grateful that we have some industry standards now. We don't have enough, but we have some industry standards. We have industry standards for documentation. We have industry standards for supervision of RBTs. These are things that it's very difficult to establish in the field of ABA. Now we have some. When I first started practicing, there were no standards. There were guidelines, and that's it. It's really nice to have some benchmarks that we are supposed to abide by in our field. And I strongly support our field moving towards more standards, but we have to figure out what those are. And I'll tell you where to find those in a minute. We have to assess our company's current compliance programs. We have to identify weaknesses and liabilities. We have to correct those vulnerabilities. And we always have to be vigilant and continuously monitor and search for weaknesses in our companies. Again, this is a everyday process that we have to bake into our companies. Now, to me, this is the 101. This is the most basic level of source information that everyone who delivers ABA services should have read once and have a record of. First of all, if you have a state licensing board, you need to know what their requirements are and maintain those requirements. I cannot tell you the number of licensed clinicians who I've spoke to who could not identify the basic requirements that they were actually held to. I had a great conversation once with someone who was in the single digits of licensure in Massachusetts. They were very proud that they were in the first 100 and they're an excellent clinician and yada, yada, yada. I met this person because there was a problem and they had terminated services for a patient, didn't give them any notice, terminated services with the patient via text message. And when I met with them, I was teaching them that to abide by the state licensure rules, they have to provide 30 days notice. The notice needs to be in writing. They have to provide referrals to other providers. They have to engage in the standards that the board has presented. So the licensure board, it's right there on the state website. It tells you the actions that you need to abide by to maintain your licensure. And those issues were clearly violated in that case. But here's someone who's very proud of themselves for being licensed very early, but in reality, they didn't even know what the standards they were held to. So at minimum, you have to know what those standards are. Get those documents, read them, and make sure you're abiding by them. We also have the BACB Code of Ethics. This is a huge document, and I understand that there are points in the BACB Ethics Code that are contradictory at times. It's a big document. I know that the document as a whole, it's been edited. It will continue to be edited, but either way, we do need to abide by our own certification code of ethics. So you have to have that and be up to date on that document as well. We have to know what our industry standards are. Again, we're lucky to have any, but looking at the accreditation requirements for organizations like the BHCOE and CASP, those are good places to look for standards in the industry. Looking at the BACB supervision requirements, et cetera. You have to look at your health insurance contracts. And when I say health insurance contracts, I feel the need to point out that most health plans manage multiple products. There's commercial coverage and there's federal Medicaid programs. There's also self-funded programs. So in some instances, you have a single health insurance company. Let's say it's an Anthem or an Optum, and they give you one contract, but in that contract is a section for commercial fully funded products. They also have a section for self-funded programs, and they also have a section for a Medicaid product as well. You need to know all of those different standards and make sure you're abiding by each one of those within your contracts to make sure that you know what you need to uphold in compliance. And then finally are your state and federal laws. And again, across state lines, rules regarding ABA often differ very drastically. So if you practice in multiple states, it's making sure within the state you practice that you're abiding by those specific state laws. Okay. The other part of compliance is that what I've found is there's a huge misunderstanding of what compliance is in health insurance. The number of people who have told me that they are doing things because someone at the health insurance company told them to do it. It's very frustrating to me because the reality is we're not supposed to you should never use someone that just tells you to do it as a source document, as cause to change your behavior. You need to do it from these documents from before. We need to take a look at the actual source documents. It's not letting me go back. Again, the license board requirements, your contracts, and the provider manuals. Those are what we look for to change your behavior. We do not take the comments of one reviewer at a health plan and then change our session note templates because of one comment from one reviewer at a health plan. That's not sufficient to change your behavior. If they ever tell you something like, and this is one that's been getting under my skin, but it's something that happens, insurance companies telling us to add information regarding the reinforcers that you used in the session, right? So they're saying, we don't think your session notes are sufficient because you didn't write down what reinforcers that you used. This really gets under my skin because I've had the opportunity to review medical notes for behavioral health, for medical treatments, for operations. When you look at the industry standards of other fields, for example, if there's an operation and they're fixing a bone in their arm, they don't ask the surgeon to identify what scalpel they used. Was it a number 3 blade or a number 5 blade? They don't ask the surgeon to identify how many pieces of gauze they used to pack the wound. They don't ask the details of what they used. What they ask the surgeon to put in their notes is what procedures they engaged in. What was the outcome of those procedures? Were there any complications? They don't ask them to document what number surgical blade they used. And that's what they're asking for here from us. What's the actual reinforcer you used? And there is no documentation anywhere that indicates that to meet medical necessity, that we document what reinforcer is in the note. So when you hear things like this, I want you to stop and ask questions. Why are you asking me to put this in my note? Where does it say, ask for it in writing, that I need to document what reinforcer I'm using? It's okay to ask questions. It's certainly okay to ask questions of funders, because what I found, and again, I was a manager of a department of people who authorize services. Every once in a while, a BCBA would go off the rails and they would start adding requirements to a provider. I did everything I could to stop this from happening. But sometimes BCBAs asked for more information than they really should, and they kept scope creeping and making things difficult for a provider. And I'd have to cut them off and stop them. But it's human nature with ABA to inquire more, ask for more information. I get it. But there are times where they would ask for things that were not actually requirements. And what would the provider do? They would do it. They'd add, what's the big deal? I'm going to add a line in my session note for reinforcers. In my opinion, it is a big deal because it's enabling the health plan to influence our standards of care for ABA. And I don't want that to happen. I want the field of ABA to develop its own standards of care and standards of documentation that do not require us to write down that the kid worked for 3 minutes of play with their toy car, right? That's not what ABA is about. ABA is about documenting what procedures were implemented. How did we treat autism, the symptoms of autism? What were the outcomes of the treatment? What were the benefits of receiving treatment that day? That's what we should be documenting, not spending time writing down that the kid played with some sensory toys or that they wore a particular reinforcer. That's not the important piece of documentation. So always ask for things in writing. Don't do things just because someone tells you to. And this is one of those pieces that really, it's amazing to me. I've worked in parallel with a number of different billing and compliance companies. And some of them are excellent, where they take the time to stop and think and say, a payer asked for this, do we do it? But most of the ones I've worked with, whenever a payer just says to do something, right? They say, hey, put information about reinforcers in your session notes. They just do it because the payer asked. A payer asked us to do it, so now all of our notes are changed. And I don't want to give payers that power over our field. I think we should have the right as ABA clinicians to document things the way that reflect, yes, we have responsibility to show that their services and they're effective and document what we're doing. But the health plan doesn't have the right to tell us what's supposed to be in that note. We have to look to our industry standard documents for that information. So again, here are more industry-wide source documents. Everyone here who practices ABA should have access to these documents. Some of them are free. Many of them are free. Some of them are not. Everyone should have the definition of autism in the DSM-5. Everyone should have a copy of the CPT code professional book. Every time the code set is updated, you need a new version of this book. Unfortunately, this book's pretty expensive, but I think it's important to have it because it explains specifically how the codes are to be billed and what the rules are. CPT Code Assistant is also a fantastic resource that actually goes through scenarios of using the CPT codes. So I very strongly recommend you have this as well for the ABA section. Everyone should also know that there is the ABA Coding Coalition. Now, I understand that a lot of the conversations that happen, and people heard about this talk itself through Facebook. Facebook and social media have a place in this world. But Facebook and social media, I don't feel have a place in discussing issues regarding coding, issues regarding contracts. We should be really careful about discussing some of that information in any sort of public forum. If you have questions on coding, I beg you not to ask them on Facebook. Go to the source. Go to the ABA Coding Coalition. This is an amazing resource that I use all the time if I have a question about a scenario and coding and billing. This is the source. You can ask them about a situation regarding telehealth and pair training. You can ask them regarding how it's interpreted, how to bill for certain things, how to use certain modifiers. This is an incredible resource, and they have incredible experts who will tell you how to do things properly. Please stop asking for coding advice on Facebook. Please go to the source. Go to the ABA Coding Coalition. You can literally send them a message through their platform and they will get back to you in a couple of days. It's a fantastic resource. Please don't talk about codes on Facebook anymore. Thank you. Okay. I always go over time. I'm going to have to speed through some of this. I'm going to try to stop early so we have some time to talk. But here's just an example of something that might be in a provider handbook.
Hey, Jerome.
Yep.
Jerome, if you got to go long, wait, we can if people need to go at a certain time, they can go, but take your time, go through it. This is great.
Okay, fantastic. Thank you. Okay, so here's just a sample of some language I pulled from a provider handbook, and it just illustrates some information that many providers don't know right away. They learn it eventually. Like they'll find out if they don't get paid, but they should know it in advance, is my point. So in this provider handbook, it says treatment record entries should be made on the date of service. The services are rendered and include the date of service. If an entry is made more than 24 hours after the service was rendered, the entry should be included. It should include the date of service, the date of the entry, and a notation that this is a late entry. This is an issue that faces many ABA providers. You have a therapist or a behavior tech or an RBT who delivers services, and they tell you, hey, by the way, I had a session from 3 to 7 yesterday. I didn't have time to put the note in. I had to run home for whatever reason, and they put the note in the day later or 2 days later. Or in some really bad instances, I see it done the next weekend. It's 5, 6, 7 days later. That's not okay. We can't do that. And some provider handbooks, not all of them, have a timeline. And they tell you that if it's late, you have to indicate on the note that it was a late note. I guarantee you in an audit that the special investigations unit that will be reading your documentation to identify if fraud has occurred is going to spot if the date of service, the signature date and time don't line up. And listen, 24 hours is a pretty tight window. In my opinion, in the field of ABA, anything after 48 hours is not acceptable. Everything has to be done within 48 hours. In a best practice, they're done immediately after treatment's delivered. But the reality is, if the note is entered late, you have to note in your session note that this note was recorded late and put a reason why. This note was late because why is this advancing automatically? Sorry. This note was entered late because technician had a conflict and it entered the note 3 days later. If you have that as part of your session note, when it is reviewed 2 years later, 1 year later, whenever the audit occurs, they'll see that note and go, oh, this provider knows the rule. If the note's entered late, they have to show us that there's a notation. They look at that and go, that makes sense to me. This provider has a good system. They've notated that it was entered late. I'm not concerned. If you have no notation that the entry was made late, and they look at the session and say, okay, the session was delivered on December 1st. Now's December 5th, and they have all this data information. It looks strange to me. Why was it signed that many days later? That raises the level of suspicion of the special investigations unit. That raises the concern of the people auditing your notes. You never want to raise their concern. So do it properly. Put a note in there that says why it was entered late and that it was late in the first place. Okay, other sample language for payer contracts. Here's another point that was made. Providers shall maintain books, records, and other compilations of data pertaining to provision of the services to the extent and in such detail as shall properly substantiate claims for payment hereunder. Okay, so this is obviously from contractual contract because this is very legalese here. What does this mean? This means that the provider has to document and record what they did to treat the symptoms of autism, to substantiate that they delivered services so they can receive payment. Some version of this statement is in every single health insurance contract, and it states that your job is to document what you're doing. I think it's perfectly valid for a health plan to require you to document and prove that you did the services. So this is why we have to have session notes in the first place. Next, we have, this is just another sample from a payer contract, and I actually like this very much because this resembles the BHCOE standards for documentation session notes. Daily progress notes should include, it says place of service, start and stop time, who rendered the service, the specific service rendered, again, they want the code, who attended the session, interventions used during the session, barriers to progress, response to intervention. These are the things they want to see in the notes, and they tell you point blank. Now, if you're missing 3 or 4 of these in your session note, let's say you don't put place of service. Let's say your start and stop time isn't the actual start and stop time. You're just putting the scheduled time. That could be a problem. Most provider manuals tell you what they want to see. I'm hoping that we can read the documents and make sure that we're meeting those standards. Here's another sample. The rendering clinician must maintain narrative summaries that relate to the goals and objectives outlined in the beneficiary's treatment plan. These narrative summaries, also referred to as session notes, must correspond to the ABA claims filed for the beneficiary. This means that there has to be a session narrative that explains what you did. You can't just have checkboxes that say, I did this and this, and I treated this and this. A narrative is an actual written account of what occurred during the session. So again, we have to have narratives. Here's another section. I know this document very well because I helped write it, but the Mass Health ABA service definitions. Here's another piece of the contract I wanted to point out. They have a list of non-reimbursable activities. You're not allowed to bill for staff meetings. You're not allowed to bill for completion of agency-related administrative documentation, like travel vouchers, timesheets, billing. You can only bill for delivery of service. You can't bill for breaks. We can't bill for checking a member's eligibility. We can't bill for report writing. I'm going to skip through. We don't have to go through all these, but report writing, this is very important. Now, why is this wording very important? Mass Health, this federally funded program, they have requirements that you don't get to bill to write a report. Now, what can you bill for? If you look at 97151, it says treatment plan development. And what they mean by that is selecting goals, creating SDs, modifying programs. If you write in your session note, during this time, I engaged in treatment plan development. It can look almost identical to report writing, right? It's very similar. You're sitting at a computer, you're adding programs, you're adding targets, you're adding SDs, you're modifying implementation, reinforcement strategies, etc. But you're not actually sitting there typing out the report. They're saying you can't actually bill for typing out the report, but if you're engaging in behavior analytic practices that are supporting the services, you can bill for it. So if you write in the session note, I wrote a report for 3 hours, they're going to recoup that money. They're saying report writing is not a billable activity. Now, if you use your language properly and you say, during this time, I engaged in treatment plan development, which is billable, you get paid. It's small things like that that you have to keep an eye on to make sure that you're in compliance with your payer's system and requirements and behavior they expect. Little things like this. Again, this is one section from the Mass Health document. This service definitions document's probably about 4 pages, but again, you have to read it and account for it in your practice. All right, documenting medically necessary services. So as a whole, the generally accepted understanding of medical necessity is that it's designed, the services delivered are designed to ameliorate the symptoms and other effects of diagnosed conditions in order to enhance health and safety, improve overall functioning, and prevent deterioration and regression. So why do I have this here? I have this because it is our responsibility as a clinical practice to document what symptoms, and again, most of us work with kids with ASD or adults with ASD. So what symptoms of ASD did we treat that day? How are we enhancing their health and safety and improving their overall functioning? Your session note narrative has to explain this. If you're not talking about any of the symptoms of ASD, we're not doing an ABA that can be paid for by a health plan. What does that mean? What are the core characteristics of ASD? Language deficits, social deficits, repetitive behaviors. We need to talk about the programs that we're running. How are they ameliorating or decreasing or ensuring the health and safety of that patient? That has to be a component of your session notes, and I often find that is missing. Here is a session note compliance checklist that I often use. This has a list of items that I am typically looking for. Not all of them are industry standard, but I like to see all of these. Again, patient name, place of service, date of service, start and stop time, total units, who rendered the service. Here we have credentials. We have the CPT code, who attended the session. We need 2 patient identifiers. So this might be their date of birth. It might be their member ID. It's a way to identify the person. And then I like to have the rendering provider's NPI as well. If you have these in your session notes in terms of the basic data of the session, this is a good starting point for you. Secondly, we need to identify what interventions have occurred. We have to have a session narrative. We should discuss the response to the interventions. We need to verify the signature, which means the date and time need to be on that signature, the credentials of the signature, or who signed, and the credentials need to be there. I need to reiterate the point that a template is just a template. The number of people who ask me for a template of a quality note, I give those out. I'm happy to do that, but I never want a provider to think that just having a good template is going to cover them. Having a good template covers about 30%. It's a good start. But to really ensure the quality of the treatment plan, you need to know how to fill out that note properly. And that's the hard part. That's the magic sauce. If you can teach your team, your technicians and your clinicians how to write a quality narrative, you are invincible when it comes to health plan audits. The most errors that occur are things that are inappropriately written or not accounted for in the narrative note. I've read the widest scope of notes, just the access to the notes that I've had, being that I've been someone who's audited and reviewed these notes for providers across the country. It's unbelievable to me, the things that people write down. There's some really wild stuff out there. Again, unfortunately, I can't get details on that, but if you can teach your team to write a quality narrative, that's your strongest shield against audits and issues with compliance. Session notes are the most important piece of defense against audits, and you need to invest time, training, resources, feedback to all of your clinicians who write session notes to ensure that they're doing them properly. Here's a list of resources for federal laws. I'd be happy to provide the slides so people can get access to these documents. These are some state regulations. Again, I'm based in Massachusetts, so here's a list of state examples of documents you should look at. Here's another resource list of documents we referenced today and things that can be helpful to providers for doing the 101. The most basic understanding is reading those documents. The 201, the next level, is understanding how those documents interrelate. And the advanced kind of 300 level course is how do I use that information to ensure the compliance of my companies? But this is just a resource list so you can get these documents and start to ensure that you're in line with what they're all saying. And I need to make the point that compliance, I see this all the time. I'll meet with a company. They'll tell me they have a compliance officer. They'll tell me they have a great compliance system. But the reality is it is impossible for any one entity to shine a light on themselves and actually give a valid, objective response on their quality of compliance. Compliance is a thing that you have to have another opinion to ensure it's the competency of the decisions being made and evaluate the quality of the program as a whole. So I very strongly commit to the statement that if you want true compliance, you need to have a third party come in and assess to make sure that the systems you set up are valid and they're not being manipulated in any particular way. So even if you have a compliance program, I still strongly recommend that you get a third party to at least do an assessment on your group to see if there are any holes that are there or present. And again, this is another thing that me and Derek really vibed over when we first met. We have the same outlook on this. You need to have a third party give a look, a good hard look. And in my case, for RadBx and my company, if I was a provider, I would want the guy who the health plans go to ask if it's valid or not. That's what we do. We act as an intermediary between health plans and providers, and we try to establish what is true north and what is appropriate and what the standards are. So I'm not telling you to come to me explicitly. There's plenty of people in the field who can do this as well. But I am a resource who can provide that kind of true north and be that compass to help your groups establish norms and make sure that you're in compliance. I spoke a lot over the past hour. And so thank you and I noticed myself rushing, but I had to get through these slides. And I hope that this information has been helpful to you. And if anyone wants to have a conversation about this after, be happy to share my contact information. I do hope that this was helpful for you all as we ran through that at a very fast pace. but I hope you're not terribly confused as we move towards the end. And I'm happy to take questions at this point.
Jerome, thank you again. And everybody, a couple of people are asking about the recording or where they can get the presentation. We're going to get this up as quickly as possible. We'll get that by the end of the day tomorrow. It'll be up. If we can get it up today, we'll try to do that. And if anybody needs to go, this recording will be up and we'll continue with from here. And this will all be in the recording. So don't worry about missing out at this point. But thank you for everybody for attending. So Jerome, I've been here taking notes, and there's so many things that we see in all these different areas. And I think focusing on fundamentals is important, and adopting, not having too much focus on any one particular area of compliance, right? We all think about compliance. We know it's a threat. We know that we have certain strengths, but there's often the weaknesses that are the biggest threat to us because we don't know what they are, like as you mentioned. But focusing on the fundamentals and being consistent across all areas of your business, right? Clinical compliance, what we're talking about today, your financial compliance, taxes, employment tax, that all that stuff, right? Your technical compliance and so on, right? Having the same approach with all of this and having discipline and looking at making sure that the details, or at least understand the mechanisms that are driving these things in certain areas, and being compliant across the board, right? And have that compliance program that you have should include all of that, right? And one of the recurring themes that we always see in these webinars when it comes to business administrative stuff is the phrase, and I think you've said it five times, maybe six, that it came out of Jerome's mouth during his presentation, but you are responsible. The concept of I just didn't know, I wasn't aware, it doesn't matter. You are responsible. If you decided that you're going to run this business and be an ABA provider, you're signing up for this. So you're taking on that responsibility as a business owner. You want to make sure that you're paying attention to all these areas, right? And when it comes to the compliance side, you don't want to turn this into every day you're sitting your people down and coaching through all these different parts of these standards, and they need to be educated on it. But trying to adopt this as company culture, right? Like having a culture of compliance where everyone on the team is aware of these certain concepts and they know where to go and find out what they need to do in a certain situation. Giving your team the tools to be able to go back and figure out, I'm writing this session note, I'm not exactly sure how it's supposed to go.
Right.
Where can I find that? Have company documentation where you've dictated exactly how you want to do it with sources to back that up, right? Where are you getting that information from? And not listening to the person that you're talking to on the phone and it says, are you talking to me? And you say, hey, Derek, I'm looking at these firewalls. Which one should I get? I can tell you what my opinion is, but you need evidence. When we're making clinical decisions, those are all evidence-based, right? We base them on evidence. So we need to make sure that the decisions that we're making are backed up by good executive decision support in this area, and that you have a document that you can go back to and show, this is where I got this from. This is why I'm doing it. It's in writing. Some person you're talking to on the phone with one of your payers telling you to change your process.
Yep.
Okay, I have no problem doing that. I just need documentation for it. We have company policies. Any change to a company policy is going to have a really good reason. It's going to have to be more than just you telling me this. So anyway, one of the questions that I have is, we have these giant documents, right? The BACB Code of Ethics is one of them. What do you recommend for staying on top of this? Not everybody can afford to hire a full-time chief legal officer or chief compliance officer. What is the overall process for there's such a massive amount of stuff to keep up with. So how does one do it and run a business?
Step one in regards to a document like the ethics document, it might be painful, but you got to read it at least once. You got to get through it, and you got to force yourself to get through it. Some of these documents are very large, but as clinicians in the field, I feel really strongly that we need to, at minimum, read these source documents once. But even having done that, it's very difficult to stay on top of all of these requirements. This is hundreds and hundreds of pages of source documents. How do we keep track of it? I will tell you a trick that I do. I run into ethics issues more than the average BCBA because I have a number of different clients who have issues and they come to me asking for advice. What I've started doing is utilizing the technology we have available to us, and I'm using to read the BACB code of ethics, and I will upload the PDF of the document, and I will say, here's the scenario I'm discussing. Pull out all of the components of this document that relate to this topic, and I will write out the scenario. I did this most recently for a client of mine who had a BT who showed up to a patient's house drunk and smelling like alcohol, right? So I typed into the system, here's the PDF, review this document, and pull out all of the points of the ethics code that relate to this following scenario. Behavior technician arrives at the patient's house. Parents smell alcohol on the technician. There are concerns that the therapist was drinking before the session. And with very little work, all of a sudden, it won't tell you what the decision is, but it'll send you a list. The resulting response to that will tell you the 15, 20 points in that entire document that relate to the issue at hand. It's your decision as a BCBA to make a decision on those. But at minimum, it gives you the shorthand of these are the things to consider. Is there a violation? And then you can think about how you're going to handle it, but have at least some kind of component and understanding of how to relate that to the ethics code, which is a very large document. So use AI. That's really part of it. Use AI in a responsible way. Don't ask for what the opinion should be, but ask what are the components that relate to it to help you make an educated decision.
My next question was going to be, do you recommend using AI to keep up with these documents? So you took care of that. So one of the things that we have when we have our compliance portal that's got we have the templates, and I want to talk about templates too, but we have the templates for all the technical compliance stuff. And when we're building those out for our clients, we'll put all the documentation in from their state, from all the latest HIPAA requirements and all the different controls, and then load in, without putting the actual name of the company, what the environment looks like at this business to help our clients tailor their stuff where it needs to be to work for them. And then that goes from them through their staff getting approved and then to a lawyer. Like we always recommend a lawyer reads it and make sure it's aligned. But I think it's important that people are aware that you can, for $20 a month, set up an OpenAI account, and you can build custom GPTs that are little robots that are purpose built, right? You put in a prompt and you say, this is the job that I want you to do. And I recommend that people do that and to help them with their research. Now, you're not going to use this for your process. Just like templates, you need to make sure that this is actually straight, because you're going to be held responsible for it. So you don't want to be held responsible for a template that Central Reach provides to you or something that ChatGPT puts out for you. But what it can help you do is build your sources for the research that you're going to do to make your decision. If you have your BACB code of conduct uploaded, and you have all the HIPAA rules and regulations uploaded, and you have all that stuff in there, you say, hey, I want you to look at your knowledge base, and I have a decision to make. Where should I look in these documents? And it helps you to shortcut it. And that's really the proper way to use those tools, so that you're not doing what ChatGPT told you. ChatGPT is just telling you where to go look. That's a really great advice as far as I'm concerned. And I wanted to learn a little bit more about the audit process. I've always said the audits are a double-edged sword. They're doing two things. And one, which is what's talked about by auditors and agencies who do audits, is to protect the general public from fraud and other bad things, stolen data and all that stuff. But it all basically just leads to fraud at the end. So it's about that, making sure that nobody is getting less clinical care than they're supposed to get, or a lower quality thereof, and making sure that nobody's paying more than they should be, right? But the second part of this is it's also there to generate revenue for the agency that is doing the auditing. We've seen whether it's a OSHA inspection or an IRS tax audit or Medicare fraud control or their OCR, whatever it is, this is a revenue stream for them. What have you seen on these audits? Could you tell us about a couple more cases? Maybe somebody who really had it together that walked away clean because they had it put together, and maybe somebody who thought they had everything perfect and didn't.
Okay, I'll start with the first example. So here's the thing. If an actual audit is triggered, I don't think I've ever seen someone who actually went through a real audit with a special investigations unit who walked out without some damages. I've never seen it. If an audit is triggered, the only reason why an audit is triggered is because they found something. It's the reality. They have something.
Is that in all cases, though, do you think? Because
For-
Medicare fraud control, like they're popping up at new companies that are just a few months old.
Yes. Okay. Let me make sure I'm explaining this properly. There are medical record reviews where they look at your records and do a search. There are quality action improvement plans that occur with groups, and then there's an actual audit. Right. If all of your records are being seized, that's an audit. Right. If they're coming in to talk with you and looking at some of your documents and a couple patients, that's not an audit. That's a medical record review. So I just want to differentiate between those, because a lot of people say that they've been through an audit, but they haven't actually. They've only gone through a medical record review. My point is, in those levels of, usually it graduates and goes. So there might be a first level review, but they're not pulling in the forensics and the big team, the people who are going to find something unless they've already found something, is generally my experience. Yes, they review smaller groups. They do medical record reviews with smaller groups, but it wouldn't advance all the way to an actual formal audit unless they have found something and they have evidence of something already. So when you have an investigation team coming to your practice, and it's that level of an actual audit, I've seen groups walk away relatively unscathed because they were able to prove that they had done what they did properly. That's also some of the work that I do, is trying to help defend providers against audits that are being held to too high of a standard. But successfully surviving an audit is doing something like only having to pay back like 13% of what they originally came asking for. That's winning, in my
Some,
opinion.
not
Usually.
all. Yeah.
Exactly. But in most of the instances, and this is a confusion I think many people have, when they say they've been audited, sending in your medical records for 4 or 5 patients for 2 months or 6-month period of time is not an audit. That's a medical record review that happens with all the providers in the network. It's not an audit. Is when lawyers are there. An audit is when your documents are seized.
So one of Donna's questions is, are audits triggered or can they just be random? So I think it's more, I think what she's talking about is probably more on the medical records
Yes.
review side. So how are
Yeah.
medical records reviews rolled out? How do they pick? They throw a dart at the map and pick somebody in that town, alphabetical order? What?
So it depends on the health plan and their process, but generally speaking, most health plans have first of all, they're not going to review, again, and this also depends whether it's commercial or Medicaid, right? If it's a Medicaid plan, they usually want to meet with every one of their providers within a certain period of time. So they might say, we're going to meet with every provider in this network over the next 2 years and just do a brief look at their records. So that might be step one, where they have a general pool that they cycle through every 2 years. The other groups they look at more frequently are usually the larger size practices that affect more of their members. So if you reach a certain threshold, if they say, okay, once this provider is delivering 20,000 hours of services a month, we're going to start meeting with them more regularly. Or once this provider is meeting with 50 of our members at a time, then we're going to start meeting with them more regularly. So size of your practice matters often, but you should expect to have medical record reviews completed by all of your payers at some point. The commercial ones are generally more spaced out. They might have a cycle of every 5 years, 7 years, but the Medicaid ones are typically a lot tighter, where they're meeting with you more often because Medicaid has higher standards than commercial coverage.
Yeah, one of the things we noticed with one of our clients, they've got 3 locations, but the Medicaid fraud control unit, and they called it an audit, but it was probably just a medical record review you're talking about. But they came in, they asked for things that were unexpected by the client because it wasn't really under their purview, so they thought. But they came in and they asked for evidence on HIPAA controls. They wanted to see their security awareness training program and stuff too. So they broadened it out. And that kind of goes back to being globally paying attention to your whole compliance picture in all these different areas as well.
Yeah, there's some groups that or some health plans that do that on initial meeting with the group to show that there's evidence they have the minimal requirements. I don't often see people asking for that after the initial. To be totally honest, it's usually done in the first year or so to make sure that the group is just generally aware of what they're required to do. If that's happening later, that's interesting. I don't often see that.
This was a new group.
Makes
It's a fairly new group, so that aligns.
That
Yeah,
makes
it's
sense. That makes sense.
all right. Kent, are you ready? I think your microphone is ready to be unmuted. I don't know if he's there. He had a question. There he is. Hey,
Can
Kevin,
you hear
and
me?
just to give you some context, Jerome, Kevin is starting off his company now, and I just got off the phone with him earlier this morning. We've been on the phone a couple times talking about compliance stuff. So Kevin is doing yeoman's work, putting together his compliance plan before he starts his company. So kudos
fantastic.
to Kevin.
Perfect.
Yeah, no, I appreciate that, Derek. And thanks for the invite. I think this has been really great, and it's a great experience and good learning. All the information you've delivered is wonderful. So I appreciate your time. One of the questions that I have is specifically AI is becoming more, how do I say this? It's becoming more of our daily life and routines. I feel like it's being integrated into the medical field faster and faster. And I've come to find out that a lot of programs, correct me if I'm wrong, and I think they're CRMs, but Central Reach is now generating AI session notes. And I know you were saying that's your shield against audits and things like in that nature. What are your thoughts on AI being integrated into some of these companies like Central Reach and whatnot? And do you think that's a route that this field is going? And if so, is it something that we should start adopting, or should we try to stay away from that, keep up and generating our own session notes, obviously from our own perspective? Thanks.
Sure. Thank you for the question. I will say that I think I have a healthy sense of skepticism when it comes to new products and technology. And what I would say is that there are proper ways to use AI and those systems and ways that are not proven yet that we should be cautious of. So when it comes to an AI system reading your notes and auditing your internal notes to determine if all the information is there that you require, I am very confident that that is a good use of AI to review the notes and determine if the information in there is sufficient to pass and submit the claim. I actually very much like using systems like that, like there's Central Reach, there's the Note AI system, there's also Brillium, there's a couple others out there that are really doing really interesting work that I like to. I think more groups should participate in the development of these systems. So using it to review the notes that exist, I think is a good use of that technology. Now, when it comes to generating the notes themselves, I am not convinced yet. I haven't seen enough samples of that to be confident that is something you can just default let it do it. In terms of generating the actual document, I've seen it work. I've seen a lot of things work on the demos, and when it comes to going live, it doesn't work as well. So I'm less confident in its ability to write the note. I have a very high level of confidence in its ability to globally review the notes and ensure that they're comprehensive and complete. So if it was me, I am very comfortable using those systems to review the notes. I haven't seen enough evidence that it is effective for writing the notes themselves yet. I know it can do it. I've seen some good notes. I've passed notes that have gone through that process, but I haven't had a big enough sample size yet to sign off on that for writing the notes themselves, if that makes sense.
Yeah, so the things that AI is great at are research, outlining, proofreading. But there's that part in between, the composition part, that really should be done by a human, right? When we're using AI to build policies and things like that, it's guided kind of bullet points and building the outline. And then the person writing it is the person writing it. I've had the privilege of going and speaking at a few bar association events where we're talking about the legal side of using AI, and if something is created, who does it actually belong to? Who actually created this material? If you wrote the note, then you can be responsible for it. But if you're going to sub out that duty to a robot who works for you, who you are responsible for, that's extremely risky in my view. Yeah, I'm right with you there, Jerome.
I think there's a good chance that in the future we can rely on it, but it's just not there for me yet. And sorry, go ahead.
No, go ahead.
At this point, given what we have access to, I think the best thing to do is to train your staff properly, to have a system in place to ensure that they're completing the notes in a comprehensive manner, and that all of your clinicians are guided to create a industry acceptable narrative of the session that occurred. The times where I've had to fail groups in my reviews are when they are, unfortunately, I can't get into all the details regarding the things I've seen, but notes that have nothing to do with ABA, notes that just talk about what the kid was wearing when they walked in the house, notes talking about introducing the kid to their boyfriend at their apartment. It's like, why did you bring this kid to your apartment? What was going on here? It's like stuff that just have nothing to do with an ABA procedure, a policy, and performance. Nothing to do with ameliorating the symptoms of ASD. It's just, it looks like you're just hanging out with a kid and taking them an ice cream. It's like, wait, why is it, they build a health plan for $350 for the session and they didn't, what do they do? That's the kind of stuff that will destroy, will lead to a provider getting in big trouble. But I wouldn't trust an AI system just to generate that yet. So hope maybe in the future, but right now I would use it more as a review tool.
All right. So for the ABA owners out there that are watching this and they've got a few light bulbs that have turned on in their heads watching this, and they think, man, I might not be quite as aligned as I think I am. And I want to maybe start the process of looking into this and making sure that I don't get caught by surprise. Business owners, we love surprises. So I say that sarcastically. We want to avoid the surprises. We don't want to let things stay in that unknown magic black box and hope that it never opens. So what is their first step in engaging with you and working with you? And what kind of things can you do for them to help them be confident in this area?
Sure. My first step first of all, contact me. Reach out to me. I'm very happy to talk with anyone about improving their practice and what they need to do. Again, I want to help the field grow and to ensure that people are receiving quality treatment. So I'm very happy to have a conversation with anyone who wants to pursue that as well with me. In terms of my actual process, my first step is to conduct a compliance assessment of your provider group, where I will read and review all of the information that your group has, from the contracts you have with your payers, to your employee manuals, to your family contracts, to your initial trainings of each level of staff. I review your documentation, your templates. We create trainings to address any weaknesses. And ideally, at the end of that process, you at least have what you'll leave that with is a roadmap and identification of the areas of weakness. So a compliance assessment is step one. After that point, typically what happens, in all reality, 3 out of the 5 people who receive a compliance assessment, typically they then sign on for some sort of compliance partnership, where I'm providing trainings to their team. Maybe it's weekly or biweekly or monthly meetings with leadership to ensure that they are moving in the right direction and are implementing strategies that will be effective for managing their company. And each of those goal is to work with fantastic people and to work with people who are also committed to the same mission. Those are my favorite relationships, are working with providers who I've trusted for years and they trust me. And we're able to work together to ensure that their companies are moving forward and advancing with all this changing technology and the changing requirements. Again, the RBT 5% supervision, minimal supervision requirement, that didn't exist 10 years ago, right? Now it does. Things change over time, but making sure they're staying on top of those requirements to provide effective services. That's really the end goal, is developing a partnership where I can work with the providers who are like-minded and always committed to improving and getting better. Those are the providers that RadBx really works best with, but that's usually an ongoing consultative relationship they work out after the compliance assessment.
Awesome. And for those of you watching this, don't let this be a lesson that you learn from after the bad thing happens. Don't let a problem occur that lands you in an audit and then decide to deal with this, because you can invest a penny now to save yourself dollars later. And it's the same thing that Jerome and I have had conversations where our mutual frustration with this whole thing is that with everything that you guys are doing and how busy you are on a day-to-day basis, it's so hard to get a business owner to sit down and review this information, get educated on it, and focus in on these details. And I know it's hard for you guys, but it's much easier to do it before an audit than it is to do it after an audit, on both sides, on clinical compliance and on technical compliance. It's really a very important thing to pay attention to. Jerome, thank you so much. I know we've taken a lot of your time here, and
I'm happy to do it.
the knowledge that you've disseminated here on this meeting is going to help a lot of people, I'm sure. But we really appreciate your time, sir.
Of course.
You're already doing the work, investing your time, your energy, and your vision. So let's make it count. Build something that works without breaking you. The EBCBA Blueprint is the way. Get started for free with our foundation course.